All right, folks, here it is, our movement coordination impairments. Now, before moving on, it's important to note that there's a lot of overlap between different classifications, not just for movement coordination impairments, but speaking generally about the treatment-based classification system here. Essentially, there is a lot of overlap, not only in how folks are classified, but also in intervention strategies. So it's really important to note that we're finding classifications that most closely align with the patient's presentation, not necessarily which classification the patient fits to a T. And over the episode of services, the patient might evolve through different classifications. So, keeping an ongoing observation of the patient throughout the episode of services can be important to note if there needs to be a change in intervention strategy. So, again, our acute low back pain with movement coordination impairments, we're thinking about folks that generally have back pain or related lower extremity pain. We would note that by doing provocation tests at the lumbar spine and provoking the patient's lower extremity symptoms. And also observing movement or coordination impairments with testing. So core activation or delayed activation of multifidi, transversus abdominis are important stabilizers there. And also note, generally speaking, pain with initial to mid-range spine movement, so active range of motion in the spine from the early on to mid-motion. Especially. So intervention strategies that you want to focus on with this population, neuromuscular reeducation, a very important intervention strategy when we're talking about movement coordination impairments. So we might start off with general simple activation training in a static position like supine or prone, teaching the patient how to contract musculature and then work towards timing as we start to integrate into activity and really matching up those intervention strategies with the functional limitations and activity restrictions that the patient has. So important to note what those are so that you can try to replicate them with your exercises. So if patients have a difficult time, say we have a mechanic who's having a tough time getting up from, say, a rolling dolly on the floor after working underneath a car, we might really focus on activation training of musculature as the patient does a floor transfer, floor to standing transfer, and palpate musculature as the patient's going through that. Now, we might have started with just general activation training earlier on in a static position and really progressed towards this higher level exercise that we're having the patient do. And also potentially restrain or bracing for the lumbosacral spine in our acute stage if we're still dealing with acute inflammatory issues here. So another shade of blue here, our movement coordination impairments, you'll note shaded different shades of blue based on the chronicity of symptoms. But now we're talking about our subacute folks with movement coordination impairments. And again, we've got folks with low back pain and related lower extremity pain that comes on with provocation testing of that lumbar spine. And note here, we're talking about mid to end range motions being more painful with active range of motion in the lumbar spine. Hypermobility with our joint mobility testing. And remember that our PIVMs are going to be stronger for identifying hyper or hypomobility than our PAs and UPAs. However, those PAs and UPAs can be helpful in identifying provocation of back pain and leg pain with different segments throughout the spine during our testing. And also we might find mobility deficits in our thoracic area or our hip area or pelvic area. So essentially, as we start to move towards that subacute and when we get into the chronic, we'll see more or a greater likelihood, essentially, of problems developing in adjacent areas. Either chicken or the egg here. So is it the low back pain that's caused changes in the hips and the thoracic spine, or is it a problem in the thoracic spine or hips that's led to further involvement of the lumbar spine. Again, chicken or the egg here, but addressing those impairments can certainly be necessary and helpful for folks when we identify them, because we can restore motion in the spine, but if it's still going to be restricted during function because of limitations in the hip or thoracic spine, we're not providing the patient the best plan there, or the best services that we can. And again, also very important with these folks, we really want to focus on neuromuscular reeducation and progress that to endurance and strength training. So more likely to start having endurance and strength impairments with this population because it's lasted longer than the acute. So essentially, it takes time for folks to get weaker and to get atrophy to develop, and this being more likely as we move to subacute, and even more so when we're moving towards chronic. Manual therapy procedures. So you might focus more on gentle oscillations or soft tissue mobilization with the lumbar spine more specifically. And think about more of our stretch type mobilizations if we find hypomobility during testing of the hips or thoracic spine. And we will want to look at those areas with these patients as well. And again, really working towards progression towards the functional limitations and participation restrictions that the patients have. So really important to consider what those are, and to know what those are, and have good communication with your patients, and try to team your exercise interventions to replicate functionally what the patient's needing to do. Now, chronic low back pain with movement coordination impairments. So presence of one or more of the following, as we can see here with the description: low back pain and related lower extremity pain that worsens with sustained in-range positions or in-range motions, hypermobility with segmental testing. So again, our PIVMs being very helpful with that. Mobility deficits in adjacent areas, and again, we saw that in subacute, and even more likely when we get into chronic, because it's been going on for a longer time, and the patient might have been compensating for a longer period of time. Diminished trunk or pelvic region, muscle strength and endurance. Again, just like we talked about with subacute, the longer this goes on, the more likely it is that the patient could have had atrophy or actually gotten weaker. That doesn't happen overnight or over 1 week. That happens over time, and becomes more likely as more time progresses. And of course, our low back pain being affected with functional limitations there. So intervention strategies, again, really focusing on neuromuscular reeducation. Are you noticing a theme here? Manual therapy procedures as well, targeted where we find mobility deficits. So you might be more inclined towards our gentle oscillations if we're talking about hypermobile segments in the lumbar spine, and really focusing towards stretch type mobilizations or manipulation position or manipulations potentially, as long as we don't find hypermobility maybe in the thoracic spine, or stretch mobilizations in the hips. And again, working towards strengthening and endurance training when we observe those impairments. And we do have those functional tests that can be very helpful for identifying these folks, like with our stabilization cuff. Now, grade A evidence we're talking about here with this particular group when it comes to coordination, strengthening, and endurance exercises. So strong evidence across the board here when we're talking about specifically addressing those postural stabilizers when we find any impairments related to their ability to contract or their ability to use those muscles when needed or for long periods of time. And little clinical prediction rule here, a little cluster that can help identify folks who might essentially respond a little bit better when it comes to our stability training. So age less than 40, so our younger folks. positive prone instability test, which we went through in the examination lecture. Our aberrant movements with movement testing. So as we go through active range of motion, are we seeing things like our Gower sign, for example, there, like we talked about in our exam lecture? Straight leg raise greater than 91 degrees, so generalized increased flexibility or generalized hypermobility we're thinking about here. So if 3 or more of these items are present, essentially our positive likelihood ratio is starting to approach towards moderate shift in post-test probability, but not quite there. And we talked about this a little bit in prior lectures here, but we might start with biofeedback training. So either through palpation and teaching the patient how to palpate, or with use of ultrasound imaging, which I'm a big fan of, because the patient gets a visual observation of their transversus and gets that connection between what they feel and what's actually happening there. And the stabilizer cuff as well, training with that. So with that little pneumatic cuff that goes on the small of the back as the patient lies on supine for testing. And we might start off with static testing, but it's important to really focus towards anticipatory training as soon as we're able, if not right off the bat. So the patient might need some practice just getting that muscle fired up. And it tends to be tougher for folks with more chronic issues, I've found. But really focusing towards movement. So functional limitations that the patient has, like maybe even rolling in bed or sit to stand transfers, teaching them to palpate or using your ultrasound imaging device while the patient is going through these different activities, and trying to get focused on preparing the patient to activate, having them activate before they actually put stress on the spine. And watch out for substitutions. Some common ones you might see, Valsalva's maneuver, by far, I think, probably the most common. So the patient holding their breath and using Valsalva's maneuver, essentially to try to brace the abdominals there. And coordination impairments, again, are static positions that we might train in: prone, sideline, quadruped. So prone tends to be really great for the multifidus, sideline for the multifidus, or perhaps the transversus, and the quadruped position commonly described. And it can be really helpful to put weights, either ankle weights on the ankles, that is, or use hand weights to try to facilitate activation with lifting those extremities off the table. So a prone Superman type position, and just lifting the arm, or including a weight to essentially provide resistance and help that activation even more so. Biofeedback training here, we'll talk about this in lab more so, but this with the stabilizer cuff underneath the small of the back, and essentially having the patient go through endurance training with this. So even just a static positioning for increments in time, 10 seconds, for example, and having them ramp that up by 2 to 3 millimeters of mercury at a time. But also having them maintain the pressure as they go through different motions in their lower extremities. And there are a ton of these that you'll see in the clinic, and really there's just too many to even talk about just in one sitting here. But you might see patients in a hook lying position, so with the prone position and the hips and knees bent with the feet resting on the table, doing something like marching. So alternating a leg lift, essentially, with a shortened moment arm by having the legs bent. Heel slide, so increasing the moment arm as the patient slides the heel out and makes the leg longer, harder for them to maintain stability. Straight leg raises, so having your patients start with the hips and knees extended, and having them do a straight leg raise while they stabilize their lumbopelvic spine. And essentially those the extremities being external perturbation, and also helping with that transition to our alternating movements, like with walking when we have one hip flexed and one hip extended. And prone biofeedback training. So when the patient's in prone and having a stabilizer cuff underneath the abdomen here and inflated, and having them decrease the pressure up to 10 millimeters of mercury, starting at 70 millimeters of mercury, holding 10 seconds, 10 times, which we'll commonly hear with this, and also maintaining pressure as the patient lifts the arms and the legs off the table. Again, in our Superman type position with the arms over the heads. And these being some very common lumbar stabilization exercises that you'll see when looking through literature, and also when out in the clinic for endurance training, strength training of our lumbopelvic stabilizers here. So just abdominal bracing. Again, our static isometric hold there. Heel slides with bracing like we talked about. Leg lifts, so the straight leg raise, essentially with our bracing. Bridging as well with the bracing. Bridging with a lower extremity lift. You'll commonly see as a progression of that bracing, and really cues in those multifidi as well. Bracing with walking as well, so an upright walking activity. And quadruped, starting in the quadruped position and lifting an arm or lifting a leg, which we'll see on the next slide here, and progressing on towards alternating lower extremity and upper extremity. So if lifting the right arm, lifting the left leg at the same time. And side bridge as well. These all being very common exercises that we'll see for lumbar stabilization. So here in this study, this shows a few of those exercises that we talked about. So starting on our left column, the top there, really cueing into those external obliques there, a plank. And our bridge, which we see on the next picture, the middle picture there, really cueing in on those multifidi, and we can make that harder for the patient by having them lift a leg. So straighten their left knee and then bring it back down, and then straighten their right knee and bring it back down. And on the bottom there in the left column, we see our bird dog, as many people commonly refer to it, I guess because it looks like a pointer dog in the field. But maybe just starting with a single arm lift or a single leg lift, and possibly progressing on to alternating upper extremity and lower extremity. And moving now to the right column, that being our side bridge that we talked about on the last slide here. Now we might start with having the patient have the knees bent to 90 degrees. That would decrease our moment arm and really cues into those external obliques here. And our traditional sit-ups that we might see on our bottom right here, really cueing into those rectus abdominis muscles.